Good afternoon, everybody. My title is Cytoreductive Surgery with Hyperthermic Thoracoabdominal Chemotherapy in Stage 4 Ovarian Cancer. A technical description. Myself, Dr. M.D. Ray. I am an additional professor, All India Institute of Medical Sciences, New Delhi, India. We know systemic chemotherapy for peritoneal carcinomatosis in ovarian carcinoma is associated with a recurrence rate more than 75%. And around 95% of the cases, the disease is confined to the peritoneal cavity. But in stage 4A, it goes beyond the abdominal cavity, and that is pleural effusion. The propensity of loco-regional treatment failure has paved the way for the discovery of cytoreductive surgery and intracavitary chemotherapy. Cytoreductive surgery is the present-day treatment modality for a variety of peritoneal carcinomatosis, including ovarian cancer, we know, along with the multivisceral resection for the completion of cytoreductive surgery. So, basis of our novel technique, in case of diaphragmatic infiltration by tumor deposits, partial resection lead to diaphragmatic rent, which can be used for the perfusion of chemotherapeutic drug into the pleural cavity. So, disease transmission from the peritoneal to pleural cavity, we know, is the poor prognostic factor. However, the intrathoracic hyperthermic chemotherapy or HITAC may be a reasonable treatment option for ovarian carcinoma with malignant pleural effusion or pleural deposit. HIPAC plus HITAC, and in a word we can say HITAC. So, hyperthermic intraperitoneal chemotherapy is added to the treatment plan in case of complete CRS, but this is a technically very challenging procedure, we all know. Therefore, performing hyperthermic intrathoracic chemotherapy on top of CRS and HIPAC may be even more complicated and more challenging procedure for such kind of advanced diseases. The technique of combining HIPAC and hyperthermic intrathoracic chemotherapy, HITAC, is also known as HITAC, hyperthermic thoracoabdominal chemotherapy. The perioperative morbidity mortality may be a matter of concern in this. Our preliminary experiences in this paper, we described our CRS technique with HITAC, which was performed in our 4 of the patient in stage 4A ovarian cancer, metastatic pleural effusion after completion of a CRS. The patients were retrospectively identified from a prospectively maintained database and had all partial diaphragmatic resection followed by HITAC as a part of CRS. So, if I come to the short description, surgical techniques are outlined along with the accompanying intraoperative images. Patient demographic, clinical and follow-up details were also described in this paper. No comparative analysis with control patient was done. Adjustment in chemotherapy dose are not mandatory for HITAC. And our 4 patients, one had intrathoracic recurrence on follow-up, but no mortality was recorded within 90 days. HITAC is a complex and potentially equivocal procedure whose toxicity profile and complexity is still poorly known or poorly understood. Morbidity was not life-threatening and survival was acceptable as per limited literature and our preliminary experiences. So, these are diaphragmatic resections we made, partial and complete diaphragmatic resection done. So, few words about the technique of diaphragmatic resection. We know the diaphragm is the second most important muscles in our body after the heart muscles, and not only it helps in respiration but also it helps in propulsion of the food from esophagus to stomach. It prevents the reflux and emesis, etc. We describe the anatomy and technique of diaphragmatic resection in this paper. Circumferential dissection of the diaphragm is the best way to prevent the phrenic nerve injury, thereby it protects the diaphragmatic function. Radial incision or a non-anatomical incision is avoided. And reconstruction of the diaphragm after HITAC. If the total dissection was less than 30% of the total volume of the diaphragm, we do primary repair, primary closure with the 1-0 polypropylene suture. If it is more than 30% or tension is there to close, then we use the polypropylene mesh to close the defect. Autologous repair also sometimes can be done with the latissimus dorsi external oblique aponeurosis, or tram flap also can be used. Routinely we placed ICD after this procedure in all our cases. So we can conclude CRS and HITAC is a complex and evolving procedure. These are viable treatment options for cases of stage 4A ovarian cancer with peritoneal carcinomatosis and pleural disease, especially in post-neoadjuvant chemotherapy setting. Macroscopic disease can be removed with CRS, and the remaining microscopic disease can be dealt with this HITAC to reduce the thoracic recurrence along with the abdominal recurrence. In this study, there are no life-threatening surgical morbidities we observed. No mortality was recorded till the last follow-up of our patient, more than a year. CRS with HITAC can be safely performed in selected group of patients and replicated easily without additional morbidity, and no need for extra resources for this HITAC. However, multi-center studies with larger numbers of patients and longer follow-up is wanted to establish reproducibility and acceptance of this kind of challenging and demanding procedure. Thank you very much.